Good afternoon, everybody. Dr. Pacheco here. So we will today continue our lecture from slide 39. We'll talk about hiatal hernias of the stomach, and after that we'll discuss other issues related to the small intestines, and we'll stop actually on the small intestines. So let's discuss hiatal hernia, protrusion of a part of stomach into the mediastinum through the esophageal hiatus of the diaphragm. The hernias occur most often in the people of middle age, but I also seen quite a lot of people later in the life developing quite frequently as well a hiatal hernia. So mostly because with age there is a weakening of the muscular part of diaphragm developing and widening of the esophageal hiatus. Hernia quite frequently give clinical presentation, so the symptoms usually relate to the pain in the epigastrial area. Sometimes this presence of a hiatal hernia may lead to pretty serious consequences, even to development of esophageal cancer. The two main types of hiatal hernia which you need to know are paraesophageal hiatal hernias and sliding hiatal hernias. Let's discuss paraesophageal hiatal hernias. They are not so common, several times less common than sliding hiatal hernias, and the whole mechanics of the formation of a hiatal hernia is that cardia remains in the normal position, but pouch of peritoneum, often containing part of the fundus, extends through esophageal hiatus anterior to esophagus. Usually it's due to increased intra-abdominal pressure plus defects in the muscles forming the hiatus. In these cases, usually no regurgitation of the gastric content occurs according to textbooks. Why? Because the cardiac orifice is in its normal position. So that is probably allows more effective work of gastroesophageal sphincter, and as a result no regurgitation. Sliding hiatal hernias, it's a little bit different and much more have more serious clinical consequences for patient. The abdominal part of esophagus, the cardia, in the case of sliding hiatal hernias, as well as part of the fundus of the stomach, they sliding superiorly through the esophageal hiatus right into the thoracic cavity. So this kind of sliding more obvious when patients are lies down or bends over, and this kind of sliding lead to regurgitation of the stomach contents into the esophagus, and partially it's also a result of two other things. Now, first of all, it's a decrease in the clamping action of the right crus of the diaphragm on the inferior end of the esophagus. All right, so a second reason is extension or stretching of phrenoesophageal ligament. So the ligament which is connected, connecting diaphragm with gastroesophageal sphincter area. One more clinical notice regarding the hernias in the diaphragmatic area. Let's talk about two more types of congenital so-called diaphragmatic hernias. Sliding and paraesophageal hernias could be also congenital, but in majority of cases they are appear later in the life. But the two types of congenital diaphragmatic hernias through the foramen of Morgani and hernias through the foramen of Bochdalik, they are more common in the newborns. For example, foramen of Bochdalik, which is a defect in the diaphragm, in the left cupule of the diaphragm. So that is appear in one of 2,200 or 2,200 newborn infants. Congenital diaphragmatic hernia result from complex development of the diaphragm, or let's say impairment in the development of the diaphragm. And as a result, the foramen of Bacteria could be pretty big, and due to increased intra-abdominal pressure, a significant portion of intestines can protrude into the left thoracic cavity. Left thoracic cavity contains lung and heart, and for lung already not so much space to develop, and in case of a presence of the loops of the bowel in the left thoracic cavity, the lung is ceased to develop. So as a result, child will be born with left-sided pulmonary hypoplasia, and this will lead to very high mortality rate due to insufficient oxygen supply. Now let's talk about vessels of the stomach. The stomach has a rich arterial supply arising from the celiac trunk and its branches, which you of course should remember very well. Most blood is supplied by anastomosis formed along the lesser and greater curvatures. Along the lesser curvature, right and left gastric arteries forming anastomosis and supplying lesser curvature. Greater curvature is supplied by left and right gastroomental or gastroepiploic, also known as arteries. The fundus and upper body of the stomach receive blood from so-called short and posterior gastric arteries, which are derivatives of branches of splenic artery. Let's talk about venous drainage and after that lymphatic drainage of the stomach. So gastric veins, they are in general they parallel to the arteries in the position and in the course. The right and left gastric veins drain into the portal vein directly, right? So the short gastric vein and left gastroomental veins drain into the vein which we seen already in cadavers, which is huge, splenic vein. And splenic vein, remember, joins superior mesenteric vein to form the portal vein. The right gastroomental vein empties into the superior mesenteric vein. A prepyloric vein ascends over pylorus to the right gastric vein. Because this vein is obvious in living person, surgeons use it for identifying the pylorus. That is very important clinical correlate. Now let's talk about lymphatic drainage of stomach. The gastric lymphatic vessels accompany arteries along the greater and lesser curvature of the stomach. They drain lymph, its anterior and posterior surface, toward the curvatures where gastric and gastroomental lymph nodes are located. The lymph nodes after that, from those nodes mentioned above, accompany large arteries and follow into the celiac lymph nodes, which are located around the celiac trunk. In general, lymphatic drainage of the stomach is a pretty complicated thing, and it's a lot of studies were done to identify most likely sites for draining lymph. That is very important because gastric cancer is a very common type of a tumor of gastrointestinal tract, maybe second most common after colon cancer. And that's why the metastasis usually they will be first appear in the lymph nodes, so the tracing metastasis is crucial for a removal or for survival or removal of the metastasis and for survival of the patient. So lymph from the superior two-thirds of the stomach drains into along the right and left gastric vessels to the gastric lymph nodes. Lymph from the fundus and superior part of the body of the stomach also drains along the short gastric arteries and left gastroomental vessels to the pancreatosplenic lymph nodes, so-called pancreatosplenic. Lymph from the right two-thirds of inferior third of the stomach drains along the right gastroomental vessels to the pyloric lymph nodes, and lymph from the left more portion of greater curvature drains along the short gastric and splenic vessels to the pancreatoduodenal lymph nodes. So as I said, it's pretty complicated lymphatic drainage. So let's talk about nerve supply of the stomach. Stomach supplied by parasympathetic and sympathetic nerve fibers. Parasympathetic nerve supply is through the anterior and posterior vagal trunks and their branches. The anterior vagal trunk, which is deriving, by the way, from the left vagus nerve, lies on the anterior surface of esophagus. And after that, it runs toward the lesser curvature of the stomach. The posterior trunk is thicker, although I have to admit it's not so easy to identify it on the real on our cadavers. Derived mainly from the right vagus nerve. After that, it enters the abdomen from the posterior surface of the esophagus and passes toward the lesser curvature stomach as well. It gives so-called celiac branches, which will join a huge ganglion of, or like a fusion of cell bodies, nerves, so which we call celiac plexus. The sympathetic nerve supply of the stomach is associated with cervical, with T6 to T9 vertebral segments of the spinal cord. So they are also interlinked within this celiac plexus. Okay, so through the greater and greater splanchnic nerve. So and after that, through the plexuses around various arteries, that those sympathetic fibers reach stomach wall. So a few clinical correlates regarding the stomach. Pylorospasm first. So pylorospasm is spasmodic contraction of the pyloric sphincter, which occurs in the infants quite frequently, somewhere within the first 3-4 months of age. Pylorospasm is characterized by failure of stomach muscle fibers in circling the pyloric canal to relax normally. So what is the mechanism of this defect in relaxation is really difficult to understand. Most likely it's defects in the either in the mediators or in the formation of a specific type of neurons which are responsible for relaxation of the smooth muscle cells. So result, food will not pass easily from stomach into duodenum, and stomach becomes overly full, usually resulting in significant vomiting after feeding. Congenital hypertrophic pyloric stenosis. Let's talk about this interesting pathology. Unlike pylorospasm, the congenital hypertrophic pyloric stenosis is marked thickening of the smooth muscle of the pylorus, and as a result that will affect emptying of the stomach. So it's excessive accumulation of the smooth muscle cells in the pyloric area. So it's pretty common situation, by the way, and that will be definitely on your USMLE exam. So keep in mind, 1 in 150 male infants and 1 in 750 female infants are actually prone to develop to some degree pyloric stenosis. Normally, gastric peristalsis pushing whatever we have in our stomach through the pyloric canal and orifice into the small intestines at somehow irregular intervals. So, but babies with this congenital hypertrophic changes in pylorus, they do not able to pass chyme into the duodenum. So, and interestingly, with time, there is an obvious progression of a pyloric stenosis. All right, so that's why symptoms can get worse and worse with time. Now, eventually, what happens is significant dilation of the stomach, So atonic changes or decrease of the tonus and contraction of the stomach as well. So bacterial activation, bacterial infection of the stomach. So could be pretty serious consequences for the child. Again, so really hard to say why patients develop pyloric spasm or pyloric stenosis. Multiple causes were identified, but nothing definitive. So, and there is obvious link to the genes. So, because twins developing much higher incidence of pyloric stenosis. And carcinoma of the stomach and gastrectomy. Let's discuss about those interesting things. Carcinoma of the stomach. As I said, one of the common type of gastrointestinal cancers is stomach cancer. So then the body of the pyloric part of the stomach contains a malignant tumor. The mass may be palpable. So unfortunately, it could be one of the just early signs of stomach cancer, and unfortunately, that is usually associated already with metastasis to the lymph nodes. So it means it's pretty advanced stage of the cancer when we what we can diagnose by clinical examination of a patient using gastroscopy. And gastroscopy considered one of the most sensitive technique to detect gastric carcinoma. And for example, in some countries with high incidence of gastric carcinoma, it's kind of routine method for examination of the patients, so to screen patients for gastric cancer. Physician can inspect mucosa of air-inflated stomach and, let's say, take a biopsy of suspicious portions of the mucosa. Due to excessive lymphatic drainage of the stomach and the impossibility of removing all lymph nodes, so that's why carcinoma of stomach have very serious prognosis, has very serious prognosis for patients. The nodes along the splenic vessels can be excised by removing spleen, gastrosplenic, splenorenal ligament. Indeed, we can remove significant portion of the lymph nodes which are draining stomach, but unfortunately the celiac lymph nodes are really hard to remove. Involved nodes along the gastromental vessels can be removed by resecting the greater omentum. However, removal of aortic and, as I said, celiac nodes and those around the head of the pancreas are difficult, and usually these are inoperable cases of a gastric cancer where we just rely on radiotherapy, chemotherapy to keep control over tumor. And unfortunately, this is not so effective. Gastrectomy. Gastrectomy, it's a very commonly performed procedure for various reasons, for gastric carcinoma, for peptic ulcer treatment. Total gastrectomy exists in several variants, what for most common variants called Bilirot 1 and Bilirot 2. Usually what we perform is partial gastrectomy, removal particular part of the stomach, and after that we create anastomosis between the remaining part of the stomach and usually small intestines. So because quite frequently we have to remove part of duodenum as well during this procedure. All right, so because of the anastomosis of the arteries supplying the stomach, they providing very good collateral circulation. One or more arteries could be easily ligated without any serious changes in the blood supply of the stomach. After partial gastrectomy, patients may retain some functions of the stomach, and even though, of course, it will be not normal life, but they can adjust their feeding patterns, eating patterns to the significantly decreased volume of stomach. And sometimes, you know what, that is actually significantly may improve their health condition, for example, in obese patients. so it may lead to dramatic decrease in the quantity of the visceral fat and may normalize glucose levels, so an increase actually lifespan. Next is well, I already mentioned that partial gastrectomy, so may be associated with removal of regional lymph nodes because of the presence of carcinoma, and because cancer frequently occurs in the pyloric region, removal of pyloric lymph nodes as well as right gastramental lymph nodes also receiving lymph drainage from this region is especially important indeed. Stomach cancer quite frequently diagnosed pretty late, and when it becomes more advanced, the lymphogenous dissemination of malignant cells involves celiac nodes to which all gastric nodes drain, and usually this is, as I said, pretty serious consequences. Later, the spread of tumors later tumors or metastasis of the gastric carcinomas could be found in the liver and sometimes in other locations, including thoracic cavity, lungs, and even brain in some cases. Now let's talk about gastric ulcers. Gastric ulcers are often lesions of the mucosa of the stomach, very common lesions, whereas the term peptic ulcer is applied to the lesion of the mucosa of pyloric canal, and more often the duodenum. Most ulcers, 90% of ulcers of the stomach and duodenum, associated with infection. And that is what was a Nobel Prize given to researchers for identifying bacteria Helicobacter pylori, which appear to be one of the major causes of the peptic ulcers located in the stomach and duodenum. So, but of course, Helicobacter is not only the cause of the peptic ulcers. Another quite common cause is severe chronic anxiety, stresses, chronic stresses, sometimes also consumption of specific type of medications which weakening gastric mucosa barrier. For example, corticosteroids or non-steroidal anti-inflammatory drugs as aspirin. The patients who experience chronic anxiety, they have very high gastric acid secretion, sometimes 15 times higher than normal patients. All right, so that also quite commonly associated with increased secretion of gastric acid in the patients with Helicobacter pylori as well. So you see Helicobacter pylori kind of causing stress of gastric mucosa and stimulate production of hydrochloric acid. So, and eventually high acid content of the stomach, duodenum overwhelms bicarbonate, normally protecting gastric mucosa, in which is produced usually in the duodenum, in pyloric part of the stomach. So, and this is damaging mucosal lining. Bacteria also erode protective mucous lining of the stomach, release various toxins which inflaming mucosa and making it vulnerable to effects of gastric acid and digestive enzymes. If ulcers erodes into the gastric arteries, what will happen? There will be severe and could be life-threatening bleeding, internal bleeding. Now let's talk about vagotomy. Because of the secretion of acid by parietal cells, so parietal cells of the stomach producing hydrochloric acid, and vagus nerve play a crucial role in the induction of the secretion. So we quite frequently, in order to decrease secretion of hydrochloric acid, especially several decades ago, one of the common treatment of the peptic ulcers of duodenum and stomach was procedure called vagotomy, surgical section of the vagus nerves. Right, vagotomy may also be performed in conjunction with resection of ulcerated area, and there are several approaches for vagotomy. There's a truncal vagotomy, there is a selective gastric vagotomy. So, of course, truncal vagotomy is not such a good thing. Why? Because it's severely affect parasympathetic innervation of not only stomach but also duodenum and other portions of the other portions of gastrointestinal tract. In case of selective vagotomy, the stomach is denervated, but the vagal branches to the pylorus, liver, and biliary tracts, intestines, and celiac plexus are preserved. So, indeed, it's not such easy to find branches of the vagus innervating anterior wall of the stomach, so that's why there's quite a lot of unsuccessful operations also was noted. All right, so posterior gastric ulcer, you need to know what else we need to know about gastric ulcers. The gastric ulcers which are eroding through the posterior wall of the stomach. They may actually damage also pancreas, resulting in the so-called referred pain to the back. So patients with gastric ulcers who have this type of pain, they always under suspicion that peptic ulcer actually started to cause inflammatory changes in the pancreas, which we call pancreatitis. In such cases, erosion of the splenic arteries result in severe hemorrhage into the peritoneal cavity, and the pain impulses from the stomach carried by visceral afferent fibers, so which accompany sympathetic nerves, of course, and this fact is evident because the pain of a recurrent peptic ulcer may persist after complete vagotomy, and this is interesting. So, a patient operated, so there was a partial resection, for example, of the stomach with vagotomy, so but pain still persists. All right, so why is it so? Because pain is mediated through the sympathetic, not through the parasympathetic nerves. Sympathectomy will decrease pain sensation, but in such case patients have a high probability that perforation of peptic ulcer will not cause any pain symptoms, and patient will just die from profuse bleeding without any pain sensation. Now let's talk about visceral referred pain. So that is kind of related to what we talk right now. So the gastric ulcers have this kind of feature to produce visceral referred pain. So, and it's usually referred to the epigastric region because the stomach is supplied by pain afferents that reach T7, T8 spinal sensory ganglia. So, and the same T7 and T8 spinal cord segments through the greater splanchnic nerve. Pain signals which coming from that area, so the brain interprets this pain as though the irritation occur in the skin of the epigastric region. So why? Because there is a kind of cross talk between the innervation of the skin and viscera, so in those spinal cord segments. All right, briefly let's review surface anatomy of the stomach, and we're almost done with stomach because next topic is will be duodenum and small intestines. Cardial orifice usually lies posterior to the 6th left costal cartilage, so 2-4 centimeters from the median plane at the level of T11 vertebra. At least if we keep in mind, so that in order to find cardial orifice somewhere on the X-rays, where to look at? Look at the posterior to the 6th left costal cartilage. Fundus. Usually it's not a big issue to find fundus on X-rays because it contains air, so you will see a gas bubble. So, but normally fundus, where it should be located? Usually it lies posterior to the left sixth rib in the plane of a mid-clavicular line. Greater curvature passes inferiorly to the left as far as 10th left cartilage before turning medially to reach the pyloric antrum. Lesser curvature, which passes from the right side of the cardia to the pyloric antrum, most inferior part of the curvature is marked by angular incisure, which lies just the left of the midline. That is, we will see not on the superficial, but let's say surface anatomy of the stomach if we open anterior abdominal wall. Now, concerning pyloric part of the stomach, so it depends on what position you examine patient. So let's say patient in supine position, laying on his back. In such case, pyloric part of stomach usually we can found it on the level of the 8th costal cartilages and L1 vertebra. And remember, we have a nice marker which allows us to detect where his pylorus should be. Remember, we studied transpyloric plane. Transpyloric plane is a midway between the jugular notch and pubic crest. So, and with this kind of midway, if you draw a line across this midway, so we will actually cross pylorus. That's why it's called transpyloric line. It kind of will divide pylorus on two portions. Pylorus in erect position, in vertical position, usually lies on the right side, and the location varies from L2 to L4 vertebra. So it's descending downward from L1 to L2, L3, or L4. So that is what regarding surface anatomy of the stomach. Now, next topic is small intestines.